Henry, you want to start off?
You have to introduce Henry now, since you're the acting moderator.
All right. I mean, you want to do that, Salman?
Yeah, Henry's a good friend, so I can start introducing. Henry's a dear friend who's got interest in fast cars and bikes, and also hiking in the mountains. Right. We were supposed to be hiking at this time, really, but unfortunately, because of all COVID, all that hiking trip to Nanga Parbat Base Camp got postponed. But hopefully we'll do that next year. So lots of neurosurgeons are looking forward to that. We already have 109 participants on board, so we're going to start this webinar. Henry is also the president of the International Federation of Neuroendoscopy, besides being a professor of neurosurgery in Germany. So Henry, dear friend, the floor is all yours. You can share your screen. Can you share your screen? You're going to start?
Sure. It's working, you're right, huh?
Yep,
can you
perfect.
see it?
Yeah,
very nice.
Yeah, it's working.
Okay, good morning, everybody. It's a great pleasure to do this webinar together, and I thank Salman for the invitation to do it, and he gave me the topic of tricks and tips in interventricular endoscopy. And indeed, there are a lot of considerations if you want to make a successful endoscopic surgery. You know, interventricular endoscopy takes place in the ventricles. We have the lateral ventricle, we have foramen of Monro, third ventricle, aqueduct, fourth ventricle. All these areas can be approached with an endoscope. The big difference to microsurgery is that we have an underwater surgery. And that is a problem. If you have some minor blood drops in the water, it may already interfere with your visualization, and then you can be disoriented, and it can be difficult to deal with that. So we should prevent at all. We have to prevent bleeding before it happens to make it safe in surgery. That's very important. When we come to the equipment, I think endoscope design is extremely important. And there are very different types of endoscopes. You know, these are the channel scopes where you have a block shaft and then several channels where you can put an optic and working channel and irrigation. Or we have scopes which have an endoscopic sheath around. And I prefer this type of endoscope because you can use the space within the sheath for dissection. You can create an artificial working space in very narrow cavities, and you can use it also for hemostasis. So for me, the endoscopic sheath is a major component of an ventriculoscopic system. Here's one example. This was an arachnoid cyst behind the septum pellucidum, creating a cavum. And you see, I use the endoscopic sheath as a retractor, so to push the neural tissue away, and I get clear access to the arachnoid membrane. I can cut it without damaging the surrounding neural tissue. So you can very nicely use the endoscopic sheath as a retractor. Of course, you need different scopes in terms of size. If you have premature newborns, or you have very narrow ventricles, you need a small ventricular scope. If you want to have an effective tumor resection, or you want to resect colloid cysts, you need an endoscope with a large working channel. Otherwise, your surgery will be very ineffective. Flexible endoscopy is nice because you can go along all the ventricular compartments via one blowhole, which is not possible with a rigid scope. But when we started with endoscopy in the 90s, the image quality is very poor. And also the guidance of ventricular scope is more difficult with a flexible one. Nowadays, we have chip-on-the-tip technology in very, very good quality, even in the flexible scopes. But the problem is, in Germany, we are not allowed to use it because these endoscopes are not autoclavable. And it is a request of the hygiene guys in Germany that we have autoclavable instruments for brain surgery because of the prions. which will not be killed by gas or other stuff. So that's why we cannot use the new types of flexible endoscopes. So what we use is a lotoscope system. It consists of a ventricular scope and endoscopic sheath and a trocar, and the sheath has lens markings that you do not go inadvertently too deep into the ventricles. And we have also a small endoscope which can be introduced in the obturator. So the trocar can be used together with an endoscope. It's called an optical trocar. And that is the advantage is that you can dilate small foramen of Monro. You see this is the conical shape here. And if the foramen of Monro is, let's say, 1 millimeter smaller than the scope, you can easily dilate it. Of course, if the foramen is very small, you should not try to open it up, because then you will damage a fornix. But a dilation about 1 millimeter in size is easily possible. This was a case of a hypothalamic hamartoma, and you see there's almost no foramen of Monro. And additionally, he has a very thick thalamostriate vein going straight through the foramen. And you see with a sharp endoscopic sheath, I would damage these structures. So that's why we make a foraminoplasty with a Fogarty balloon catheter to make it a little bit wider. And then we use this optical trocar to dilate the foramen a little bit, and I can get access into the third ventricle. And you see here clearly the hamartoma on the left side of the hypothalamus. And you see when I go out, there is no damage to the fornix, although I dilate it a little bit. So that's why this optical trocar is really good to get access to the ventricle via small foramina. And what for me was very important when we designed the scope to have a large working channel, 2.9 millimeters. And this is very important when you deal with colloid cysts, because you need a big suction tube to evacuate the cysts. And the trocar has lens markings, very important, because I was expert witness in one lawsuit, and the guy puncturing into the midbrain and to the frontal skull base because he was aware of the depths of his trocar. Then it's also very interesting when you have a rotational mechanism here. So you don't need to rotate the whole system, but you just can lose the screw here, and then you can turn the endoscope around 360 degrees. That is very nice if you deal with pineal lesions. You want to make an ETV and you want to take a biopsy. When the endoscope is in the regular way, the working channel is up. So you make your ETV. Then you tilt the endoscope a little bit backwards to the pineal region. And then you turn the endoscope 180 degrees. That means the working channel is down. And with this maneuver, you reduce the amount which is needed to tilt the scope. That means you have not so much shearing stress at the foramen of Monro. So it's very helpful to turn it in these conditions. And we have a smaller system for simple ETVs or for biopsy in small ventricles or for children. The diameter is only 3.6 millimeter. Of course, the working channel is a little bit smaller, but still we have a very good optical quality. The trocar is available for this procedure. So when we look at the tip of the scope, this is used for tumor resections, arachnoid cyst fenestration, colloid cyst resections, and the small one is used for ETV, biopsy in small ventricles, and in newborns, or premature newborns. And you see the optical quality is because I think although we have on the tip technology, it's the best image quality you still get if you have a rod lens system and an HD camera. We use the image 1. This is the first version. I like it very much because it is a perfect image quality. And we have diagnostic scopes. We have 1.2 millimeter scopes and 3.3 millimeter scopes for inspection. So you have different angles of view, 0, 30, 45, and you can really look around and have a good view to all structures. Here, for example, as one example, we go into the foramen of Monro. This is the fornix. anterior commissure. This is the contralateral foramen of Monroe. It's a 45-degree endoscope. And you see, I only rotate the scope and I can have a look around and see all the anatomy without doing any damage to the brain because I rotate only. Anterior commissure, lamina terminalis. This is a chiasm, and you see it was a child with a medulloblastoma, and you see all the metastasis in the ventricle. So it was intraventricular spread of the tumor. And now we can turn it backwards, and I can even have a look to the entrance of the aqueduct. And there's no movement of the scope, it's just rotation. It's like a radar, you just rotate the 45-degree endoscope. And here you see how is the quality of the image with an HD camera and a rod lens. You see even the erythrocytes going through the blood vessels if you have close contact with the scope. And this is to the vessels. So the image quality is really amazing. And I personally like it more than the new 4K cameras because of the color fidelity, which I found better in the HD cameras. This is a view from the posterior part of the third ventricle after resection of a pineal tumor, and you see what view you can get. Now I should ask you, but that takes too much time. This is a fornix here. This is the anterior commissure in between two fornices. And down here is the lamina terminalis to get a nice view around. So of course, when you do intraventricular work, you need instruments to work with. And we have a large tumor resection forceps, is 2.9 millimeter, only 2.7 millimeters in diameter. So very effective. We have a small biopsy forceps, grasping forceps, and a scissors. And my advice is if you want to buy a scissor for an endoscope, take a scissor where one blade is fixed. It's much easier to control it than you have that kind of scissors where both blades are moving. Especially in narrow spaces, if you cut close to the basilar artery or other important structures, you can bring the one blade close to the structure and then you just close the scissors to cut. If both are moving, it's much more difficult and the danger is higher that you damage some vessels or other stuff. And this is a very nice instrument. It's a DEC forceps. Philippe Deck from Paris developed this. I like it very much because there are the teeth outside. This is used for cerebroventriculostomy or for other perforations. You close the forceps, go in, and then you open it and you can make initial perforations. Very nice instrument. And of course, it's very useful that you know how deep you have introduced the instrument into the channel. That's why it's here a length marking. You go into the ventriculoscope and you see this marking. If this marking is at the entrance of this funnel-shaped entry port, then you know the tip is exactly at the tip of the endoscope. So this makes it easier. And you can also turn here with this wheel the instruments and can move the blade without moving your hand. For cutting, we have scissors, but what is very difficult to cut is a thin layer of arachnoid, which is overlaying of a vessel. Because you always come with your scissors directly with the tips of the scissors to the vessel, and there's a danger that you can damage it. With this guillotine knife, you go with this foot plate under the membrane, you elevate the membrane, you can see there's nothing in between, and you just close it and you can cut. So for arachnoid cysts, I found it very nice. You see, this is a regular scissor. I try to cut this membrane, but below is an artery. You see, it's dangerous because always the tip of the blades goes down to the vessel. So now I come with this guillotine knife, I bring it under the membrane, I lift it up and you see clearly there's no vessel in between, and then you can take the blade and cut. My only complaint is that this blade is not as sharp as I want to have it, but they said to me from a technical standpoint, they cannot make it sharper. I would like to have it like a samurai sword, that you just touch it and it's cutting. But it's very helpful for arachnoid cyst fenestration, Sylvian Fisher cyst or other cysts. I like it very much. So for hemostasis, we have different techniques and instruments. What I mostly use is a bipolar diathermy rod. This is one electrode is the other. It's very effective. It's not sticking too much. Sometimes we take this bipolar forceps for choral plexus coagulation, for example. And what you need is irrigation. You can take a machine for irrigation, but in most of our cases, we use such a syringe, which is filled with lactated ringer solution, and then we connect it within a small tube. And sometimes when we use the dry fill technique, we have a suction catheter, and it's a Chaillet size 8, means 2.7 millimeter in diameter. It fits easily through the working channel of the laparoscope and can be used for choroid cyst evacuation, but also for removal of bloody CSF. This is a forceps which we use for choral plexus coagulation. It's very effective. In general, choral plexus coagulation, we perform it very rarely in hydrocephalus cases. We had one girl, she had an hypertrophic choral plexus and obviously an overproduction. In this child, it worked very well because she was shunt dependent and had severe ascites. And after coagulation of the plexus, this ascites resolved within 24 hours. Very, very nice case. But in general, we do not so many cases. So small chamber irrigation technique is one maneuver what we use for bleeding. When we have a bleeding, of course, we start with irrigation, but usually you don't see much. And if you are in a large cavity like a lateral ventricle, you cannot clear this because it's very bloody. So we start with forced irrigation, and then we go very close to the bleeding point. Sometimes when you have a forced irrigation, you have a glimpse of the anatomy around. So slowly you go closer to the bleeding point, and then we take this endoscope back about 5 millimeter into the sheath. So we withdraw it a little bit, and then we create a small chamber in front of it. And this small chamber you always can clear. And then we go very close with the margin of the sheath to the bleeding point, and then you can have hemostasis under direct vision. It's also very interesting or very helpful when you have a tumor bleeding, because you really go to the bleeding point, put the scope on it, and you have.
Sorry, Henry. Can you slow down a little and increase your volume a bit, because some of the people can't hear you very well.
Okay, but I don't know how to make
you just need to come closer to the computer.
It's
okay.
Better.
So? It's better.
All right, good.
Thanks. Sorry.
No, it's fine. It's fine.
So continue with your bleeding now.
Yeah. This is a case of an arachnoid cyst. And I use scissors, and you see inadvertently, I cut one small side branch of an artery. And you see immediately you have this Japanese flag. So that means you don't see anything. And then you stay calm. You take your irrigation syringe, connect it, and you start to irrigate. And you see there is a glimpse of anatomy around. And then I go closer with my endoscopic sheath. Again, irrigation, and you see here is a vessel, and obviously here is some bleeding point. This is a falx. Irrigation. And then I take my bipolar rod, and I just compress the vessel, and you see it stops. I see the vessel here. This is a falx. And here, there seems to be the side branch where it bleeds. So I go back a little bit, and you see, yes, clearly this small side branch was a problem. It's interesting when you see it under the endoscope, you think it's a terrifying bleeding and it's a disaster, but it's because of the high magnification of an endoscope. When you would do microsurgical fenestration, you have this kind of bleeding, you would say it's nothing. But in the ventricular endoscopy, you don't see very well because of all the blood. And that's why you have the problem with orientation. So just coagulation, and then it's fine. There's another technique, small chamber irrigation technique. It was a colloid cyst. I have a bimanual technique. I pull on the cyst with a forceps on the left side, and then the main channel is a bipolar diathermy rod. I coagulate 3 times, and then I thought it might be okay. And I took scissors and cut it. oh shit, was too early. Although I coagulated several times, it's a small artery, it's not a vein, it's an artery, that's why we have still bleeding. So what we do, again, you see it becomes red. We don't see very well, so we start with irrigation again. And then I have to be careful because the fornix is here around. So I have to see a little bit. You see, I go back in my endoscopic sheath, start with the irrigation, and then I use my endoscopic sheath also a retractor. I go into the third ventricle, and then here you see my endoscopic sheath. This is a I create, and then I push the fornix up, and only with this maneuvers I can get access to the telechordia, where this blood vessel is arising from. And with bipolar diathermy, we can coagulate this artery and can continue with the surgery. So in my opinion, it's quite a useful technique. The dry feed technique is a rescue maneuver if you have really severe hemorrhage and you cannot control it with irrigation within a short time. We published this first time in 2002 in colloid cysts, and Joachim put some of our cases together in a recent publication. You see here, it's a colloid cyst again. And there was a miscommunication between my assistant and me, and he was pulling. He should only rotate, but he pulled, and you see this is severe hemorrhage. Again, it looks very terrible, and you think, wow, this is a disaster. What should we do? We have to stop. We have to convert to microsurgery, or we abandon the surgery. But we can also use an endoscopic suction, remove all the CSF from the lateral ventricle, down to the foramen of Monroe. In all of our colloid cyst cases, the hemorrhage stopped spontaneously. I just removed CSF. I didn't find the bleeding vessel. Just because of removing of the CSF, this coagulation process started, and we had hemostasis. Here we coagulate, but this is just the clot. It's nonsense. It's not the bleeding source. It's just the clot. So the dry feed technique is, I think, if you have hemorrhage, control with irrigation. And you see how clear is the view after we removed the clot and we continue, and also the fornix still intact. This is a view after, okay. So we have a flexible forceps, which is used for the bimanual technique because the side channel has an angulation here, so we cannot use a straight instrument. And with the left hand, I take this flexible instrument, and as the right hand, the main instrument can be a scissor, it can be a forceps, or as you wish. And if you have your cystic lesion here, you can elevate it with a grasping forceps, and then you can take scissors and can cut it. I think it's very helpful because otherwise this small capsule falls down to the vein, to the fornix, and it's a higher risk that you damage the surrounding structures if you use a bimanual technique. It's a little bit tricky, but it's worthwhile to do it. Another point what is very important for me is to use an endoscope holder. I know many people don't like it, and if you have an experienced assistant who can hold the scope for you, of course you don't need it. But if you work with a resident who has not experience with that, or you are completely alone, then I think it's a very helpful and very reliable. And we use this Mitaka arm. It's a pneumatic arm, just press this golden button, and you can really adjust the endoscope to the position you want. Irrigation.
Can you say that again? Sorry, we missed that last sentence.
About what?
I think it's about the Mitaka arm, Henry.
Yeah, I think the Mitaka arm, for me, it's very helpful if you have not an experienced assistant with you. And it's very easy to work with it. You just press this golden button, and then it's released, and you relieve the button, and it's fixed, and it's quite stable position. Of course, you have a little bit subsiding of the scope when you leave it, but I think it's the most reliable endoscope holder I have seen so far, except the big robotic things which are very bulky. So I like it very much. For irrigation, usually we have such a syringe with the catheter ring solution. But if you have a tumor case and you know it's a lot of bleeding, you can have an off-label use of the artro pump. So artro pump is used for the orthopedic surgeons for knees. You see the pressure goes up to 200 millimeter mercury, so you have to be very careful. And the flow is, I think, 1 liter per minute. So it's a lot, but if you bring it down here to these levels and you place it correctly, it's really helpful for irrigation because it's volume and pressure controlled. But of course, it's off-label use, so officially you cannot advocate it. What I see frequently when people start with the endoscope is they bend this instrument in the shaft because you want to have the instrument left or right. But of course, it's not working because the instrument is within the working channel of the endoscope. So that's why with the left hand, you guide the instrument left side, right side, up, down. With the right hand, you only control the depths, how far you go in, and you can open and close it. But this is completely normal. You look at the screen and then you want to move your instrument left, right. This is one important step what you need to learn. So neuronavigation is very helpful, especially if you approach the ventricles from an unusual trajectory. We always use it for colloid cysts where we come from an anterior lateral point. We always use it in small ventricles and in cavities where we have no anatomic landmarks, for example, in ependymal cysts. Also for multilocular hydrocephalus, it's quite useful. For normal ETV, we don't use it. Many of my colleagues in Germany give criticism to me because they said, why you do that? You can increase the safety, you have it. And of course, they are right. It can happen that the trajectory is not ideal and then you have to correct the position of the scope. But I think in large ventricles, it should be safe to puncture it freehand. But maybe it's a little bit old-fashioned. We can discuss this later. Then you have to have a convenient position. Usually we sit, sometimes we stand, and we have the screens. One is with an endoscopic view and one is a navigation image. And sometimes if there is an emergency case, we have a lot of screens. You can also see other important messages which are required in the OR room. So what is the utmost importance is planning. As in any surgery, we have to have a careful planning of the approach. So in microsurgery, if your craniotomy is not ideal, you can look a little bit from the left side, a little bit from the right side. But in endoscopy, you have one borehole, and if this is wrong positioned, you can be in really trouble. You have to correct it, or you cannot complete with your surgery. So we have to look at the MR images. For hydrocephalic cases, we have the standard sequences, but in the sagittal view, additionally, we have the flow-sensitive inversion recovery topospin echo sequence, which usually gives the black signal when there is flow, and you see within the aqueduct is no flow. And then we use CIS. This is a T2-weighted high-resolution image, constructive interference in steady state, and you see very nicely the bulging of the lamina terminalis. You see the wide angle of the stalk, distortion of the stalk, bulging of the floor, pre-stenotic dilation of the aqueduct. And you see also the membranes in front of the brainstem. So very useful information for the planning of your procedure. So what are indications for intraventricular endoscopy? A lot of indications. Any type of occlusive hydrocephalus can be treated with endoscopy, intraventricular tumors, colloid cysts, arachnoid cysts, pineal cysts, and also ependymal or intraparenchymal cysts. The selection of the approach is very important. Usually in the seminars, I always show this image and ask the people what to do. And then of course you say, this is a lady with a mass in the aqueduct. She has headache, vomiting, nausea. So what we want to do is to treat the hydrocephalus. You see the bulging of the floor. So the main task is to make an ETV, but then we want to take a biopsy. Is this possible to do it via one borehole, or do we need two? And usually people say, no, I just need one. And then I asked, what is the prerequisite to do it from one borehole? And then people thinking. What is the bottleneck of the approach to get here? It is the foramen of Monroe. And people sometimes don't look at the size of the foramen. They just go in and then they wonder why it was not working well. You have to look at the size of the foramen of Monroe. And you see in this case, very small foramina. If you do this procedure from one borehole in this lady, you will destroy the fornix and or you have severe hemorrhage from the vein. So this should not be done. In this case, you need a trajectory straight to the ETV and take a flexible for the biopsy, or the other way around. You make a straight approach to the aqueduct and take a flexible for the ETV, or if you don't have it, you really need 2 boreholes to do it. If you have a large foramen of Monroe, like in this case, of course, you see easily you can go to the floor and you can go to the posterior part of the third ventricle. So you have to look at the foramen of Monroe on the pre-op MRI. It's very, very important. If you see such a small foramen, you are not able to do that maneuver, and you need 2 approaches. So occlusal hydrocephalus, what can we do? A lot of techniques: septostomy, foraminoplasty, ventriculostomy, aqueductoplasty, stenting, all can be done. ETV is the most frequent one. The borehole position is usually at Kocher's point. We go directly to the coronal suture, around 2.7 millimeter aside. So we don't go 1 centimeter in front, just at the coronal suture. In my opinion, that is the best approach. Then we look to the floor of the third ventricle, mammillary bodies. Here is the infundibular recess. And it's very important. It's really very important. We had one deadly complication because one of my guys did the perforation at the wrong area. Even if the basilar artery is here in front, you have to go in front. Never go in the back of the basilar tip and make perforation. Race and go to the.
Sorry, Henry, can you go back to never go, because we missed, there was some voice problem. Never go behind.
Is it not a good connection?
Yeah, there's some problem with the connection.
Mostly
maybe every
it's a good
few
connection.
minutes. Generally, it's
Mostly it's a good connection, but at times it sort of the sound goes. But I think what Salman is asking is, you talked about where to do the ventriculostomy, and just make sure that you do it something, and I think we all missed that part.
Yeah. Okay. So even if the basilar artery is located more anteriorly than usual, so not here under the mammillary bodies, but if it's here, you still have to make the opening in front of the basilar. You should never go behind, because the small perforators from the basilar go to the midbrain in this area. And we had one deadly complication because one of my guys made a perforation behind the basilar, and then he inflated a balloon, and one of these perforators was torn off the basilar. And then there was severe hemorrhage, and he waited for half an hour until this bleeding stopped. And then on the ICU, there was a severe rebleed, and the patient died finally. It was an old guy, but nevertheless, it was a surgical mistake. This should not happen. In general, ETV is a very safe procedure, and is the only one of our complications where a patient died from a technical error, because the perforation was here, because this looks very thin. This was not thin. And then he made here the perforation, but it was in the early 90s. So it's a long time ago. So we make the perforation usually halfway in between infundibular recess and mammillary bodies, just in the midline. It should be just behind the clivus. This is the ideal position of the fenestration. And we use a deck forceps. We never use a flexible catheter to make the ETV, because sometimes the floor is a little bit stiff, and then the catheter sliding to the left side, to the right side, and makes not the hole there where it should be. And then you always go in this hole again. You cannot make another one. It's very difficult. That's why I take a straight, rigid instrument, makes a perforation, and then we take a balloon catheter to dilate it a little bit. And you see, we have to open the floor, and then we have to open this membrane below. What is this membrane? a Lydiquist membrane. It's very important to open this again. If you only open the floor and you have no pulsatile flow because the membrane is intact, your ETV will not be successful. What we want to see after the ETV is we want to look through the fenestration to the basilar cistern, and you need to see the basilar and the vessels. We had one case where we had the fenestration too close to the clivus. We end up in the subdural space. So we just saw arachnoid, not the basilar. And then, of course, it's not working. You have to end up in the subarachnoid space. It's very, very important. One example is a young lady presenting with chronic hydrocephalus. You see the dilation, lateral ventricle, third ventricle. All the whole brainstem is pushed down. Here is a small tactile glioma. And tactile gliomas are really a very, very good indication for ETV. We have 100% success rate in these lesions. Usually it's a very nice surgery. You see this is a foramen of Monroe, septal vein, coral plexus, thalamus striate vein. You see mammillary bodies, P1, P1. This is a basilar tip. You see here's the perforators. And then we use the deck forceps, open the floor, and then we take the Fogarty balloon catheter to dilate it. There is a special double balloon catheter available, but it's very expensive. So we never use it. We use this Fogarty balloon. It's, I think, 35 euro in Germany. You have to play a little bit with the balloon to have the floor really at the circumference of the balloon to make a dilation. You see, this is the Lydiquist membrane below the floor. And that is very important that you also dilate this membrane to have a good flow. So usually ETV is a straightforward procedure. You go out, you see this is a clivus, just behind the clivus. And then we use a 30-degree endoscope to look into the prepontine cistern. If you see the basilar in that way, you know it's a good surgery. And also you have seen the pulsations. When you see the floor is pulsating, then you know it's a nice, usually it's a nice result. And you see this is a post-op MRI, shows the flow void in the aqueduct, in the ETV area. There's also one type of hydrocephalus, which is usually a communicating type, but Dr. Kehler from Hamburg has coined it extraventricular hydrocephalus, extraventricular intracisternal hydrocephalus. And there's really some cases they have an extraventricular CSF pathway obstruction. And you see it on the MRI, you see in the CIS sequence, you see all these membranes between the clivus and the membrane. If you see that, then you know it can be successful, although you see aqueduct seems to be open, but you see the floor is bulging down. So we go in, this is a little laparoscope, it's a small foramen. We go into the third ventricle, mammillary bodies, infundibular recess. We open the floor with a deck forceps, Fogarty balloon catheter. Dilation. We see there's another membrane. We open it. Lydiquist membrane. And now we take the sheath of the scope and go into the prepontine cistern. You see there's arachnoid, the Lydiquist. So we take scissors to open it. And this sheath protects the basilar. You see there's a basilar, but this endoscopic sheath protects this. Of course, it's not going in all the subarachnoid spaces, but if there's enough space, you can use it. And you see there is another membrane further down. So it's not Lydiquist. This is a membrane far down, and you need scissors. You cannot open it with the balloon catheter because it's so far down. Of course, if the space between the basilar and clivus is not large enough, you cannot force the endoscopic sheath in the space, but in adult case it is possible. And you see here, what nerve is this? Down here. This is abducens nerve. And now you see there is a pulsating starting. So we have all these membranes open, and you see the floor is pulsating. So we restored the CSF flow in this area. So tetrarticular hydrocephalus is also a very, very nice indication, even though there is only a little bit of space because this dilated ventricle pushes the brainstem at the clivus. Usually you find an area where you can make an opening. And if you create an opening, then usually the floor comes up a little bit and you can do it. It's also a nice indication, just an ETV, and you see the ventricles decrease in size very nicely. Shunt failure, if there is in the MRI a sign of obstructive hydrocephalus, the patient comes with a shunt insufficiency and he's older than 2 years, then we try usually an ETV. And this is a lady, she had a shunt 40 years ago, had no problem so far, and then she came with this shunt problem, headache, nausea, vomiting. She was a visitor from another area. Small ETV. We removed the shunt, and immediately she was shunt independent. You see the ventricles came down. Sometimes you have patients which need some time until they start with the resorption. So in these cases, usually you have under the borehole a bulging under the gallia, and then we make a lumbar puncture, release the pressure. Then after 2-3 days, again the gallia come up, another lumbar puncture. And then after 3 punctures, some of the patients are doing well. Of course, there are some patients where ETV is not effective, and then you need a shunt revision. But if there is a sign of obstruction in the MRI, I would advise to try an ETV in these cases because you can get a lot of patients shunt independent. Henry,
this is Moody. Just a question. I think there are 2 questions that were raised by 2 participants. If it's okay?
Yeah, sure.
Yeah. There was a question as to when you're trying to open the floor, what are your thoughts on using coagulation during that time? That's how I understood the question.
Yeah.
What are your thoughts on that?
Usually we try to avoid any coagulation. We had 2 or 3 patients where the floor was very tough after ventriculitis, and I know I'm exactly over the dorsum cellis or over the clivus. And this area I use coagulation. Otherwise, usually I don't do it because you never know whether there are some small vessels under the floor, some perforators, which might be damaged. So usually only blunt. If this is not possible, we had a few cases that's very, very sick. I use the bipolar, but usually if it's very tough, I prefer scissors to open it. So I go in with my scissors and open it. I don't cut it, but I take the sharp tip of the scissors, go in, and then I spread the scissors to open it. So I would not cut because you never know what is below. What was the second question?
The second question was another participant asking for what volume you place into the Fogarty catheter. It's often given on it, but how much do you use?
How much what? Volume?
Volume, yes.
No, it depends.
Inflation of the balloon, yeah.
Yeah, it depends what kind of balloon you have. We have 2 French, 2 French Fogarty catheter and 3 French. And it depends on the shape, how much is going in, but you see how far it's open. So I have a control not on the volume, so I don't measure it in the syringe, but I look at the image and see how far it's open. And usually it should have the size of at least 4 millimeters in ETV. Of course, if you have a wide ventricle, a wide floor, you can do it much larger. And sometimes you have cases where it's a very narrow flow, then you can achieve only 3. But an average, we have 4 millimeters. That means my diagnostic scope should fit in that I can look to the basilar. And we use a 30-degree endoscope with 3.3 millimeter in size. So it's not a control by volume. I would not take a volume and dilate it, but I look what's happening down.
Okay, Henry, can I ask you a question?
Sure.
We looked at the cases that we used to do, and without using image guidance and with image guidance. And with image guidance, we realized that the burr hole that we're making slightly anteriorly on the coronal suture was probably not the ideal site of entry in adults. And for that,
Exactly.
usually the site is at least a centimeter or centimeter and a half behind the coronal suture when we looked at with the help of image guidance.
No, we usually did it 1 centimeter in front, and I agree this was too far anterior, so we had to elevate the fornix a bit. But now we place it exactly at the coronal suture, and we found it fine. I think there's a paper from Peter Nakaji. He also investigated, and he also found that the best location is just a little bit behind the coronal suture. But we are happy with the coronal place. There is never the problem that we had to do any damage to the fornix. But of course, you are right. There are several cases where you can optimize the approach, and there might be people where it's better, even better when you go a little bit more posteriorly. But 1.5 centimeter is a little bit too far in the back, I think. That is very wide, very far backwards. You can also, if you don't have image guidance, what we previously did, we go to the MRI and we draw a line from the floor through the foramen, and then you end up at the entry area, and then you know how far you have to be away from the coronal suture. But 1.5 is, yeah, it works still. But you know, then the trajectory when you come, oh, this was a bird behind against the window. I think at least it should be at the coronal suture a little bit backwards, but not so far in front. I agree with that, yeah.
Okay. Adrian,
So how
welcome as well. Adrian is here as well, so I just welcome him. Adrian, you're unmuted. Yeah, sorry.
How long should I talk? It's now 50 minutes.
Yeah, your talk was supposed to be for 20 minutes, but it's okay. We are enjoying it. You can do another 5-7 minutes before we see the case with Ramesh. I'd leave it up to Moody, the moderator.
Yeah, we can stop now. It's up to you.
If you've managed to give all the information, I think we can take a few questions, and participants can ask. But first come, first serve.
Hi, Moody.
Hi, Ramesh. How are you?
Not too bad.
Good to meet you after so long.
I know. I just want to just ask Henry something. You mentioned about this arachnoid knife, which I think is as a good instrument, and you found that often it is difficult to cut the arachnoid with the blade sometimes. I wonder whether you could use it like a miniaturized monopolar instead of that knife with the same instrument design. Just my comment, and I don't know what you think about that kind of possibility, Henry.
Yeah, usually if you coagulate the arachnoid, it becomes more thick. So when I had the arachnoid cyst and I coagulated, it shrinks together and becomes very thick. So in my experience, sharp dissection of the arachnoid worked better than coagulation. I don't use any laser. We had a laser some years ago, but we abandoned to use it. Maybe the new laser can cut easily, but I don't know. When you are exactly over a vessel, I would a little bit careful to cut it. I think I would prefer a mechanical cutting with a sharp blade.
There's a question, Henry, about from the participants about the biopsy of lesions in the pineal area. What are your thoughts?
Yeah, we do it a lot. This is what I told, that we turn the endoscope. So when you take when you want to take a biopsy, then the borehole should be now the ideal approach for the ETV would be here. This is a coronal suture. So we go here to the floor, but then it's very difficult to come to that area. So if I see that the foramen of Monro is large, like in this lady, I would go 2.5 centimeter in front. So I have still the ability to make my ETV without damaging the fornix, but I will be able to tilt the scope to go back, to take a biopsy. But I would turn the endoscope 180 degrees because the working channel is in the front. So when I go here, my endoscope is in that way that the working channel is in front. I take a biopsy here. Then I tilt it to this area, but the working channel is still in front. So I will come up here. When I rotate the endoscope channel is downwards, and then easily I can go to this lesion. So I avoid the amount of tilting. That's why the idea to rotate the endoscope 180 degrees for that procedure.
Moody, any more questions? You want to raise somebody's hand so that anybody wants to ask a question?
Yes, would somebody raise their hand? Because the questions are not on the screen, are only coming partially. So I can't read the whole question, unfortunately.
So if anybody wants to raise hands, and we will switch on their mic.
Amir Sohail, would you switch on Amir Sohail?
Imad, can you do that, please?
Yes, sir.
And then Khalif Abdi Fatah.
Okay, Amir, go on. You're asking a question. Amir, you're switched on. Can you want to ask the question? Okay, who else wants to ask?
Abdi Fatah, Khalif.
Well, I can, Moody, you can just read out that question, maybe easier, because the question is, you can.
I can't read the full question. Just
Khalif, can you ask the question yourself? He's switched on.
Yeah, thank you so much, Professor.
Where are you from?
For the excellent presentation. I'm from Kenya.
Right.
Thank you for the presentation. I just wanted to ask, Prof, how long do you wait until you decide whether your ETV is working or not? When do you want to re-explore? And after how many ETVs do you decide that this ETV is not going to work anymore and convert to diversion?
This very variable, depends from the indication. For example, when we do an ETV in a patient who had the prior bleeding but has an aqueductal stenosis, we open up the floor of the third ventricle, we look to the cistern, we see there's a lot of scar tissue and a lot of membranes which are not worth to open it because there are many layers of arachnoid membranes, not just one. Then if this patient would fail, we would not come in again for an ETV, but we place right away a shunt. Sometimes we have patients, we open the floor and see it's a catastrophe, so we place in the same surgery already a shunt because we know it's just an attempt. If I know from my first surgery it looked very nice and he came back with enclosure what I can identify on the MRI because there's no flow void anymore, we would make a re-ETV and open it again. So we had some cases where we have a reclosure and we open more of the arachnoid membranes below the floor and then they were doing fine. And if the patient has a shunt dependence before and we place an ETV, we would try some lumbar punctures and we would wait, let's say for 1 or 2, for 1 week or maybe 10 days. And of course, it also depends from the condition of the patient. If the patient is doing fine, there's minor problems, we can wait, but if he is severely deteriorating and ETV is open, that means that the resorption is not working well, then we place a shunt. So there are many factors which influence that decision. It's not just one.
There is another question from somebody who comes across as Ninad Sawata, somewhere, something like that. I can't read the full question. Could you please unmute and ask your question? Nina?
Yeah,
I
Nina.
can read it.
Yes,
Nina
sir.
Where are you from? Please introduce yourself and then question.
I'm from
CG.
I'm from Chitra. I'm from Chitra Hospital, Kerala, India.
Okay.
My question is, what is sir, experience of professor in hypothalamic hamartoma and how commonly we use endoscopic for the hypothalamic hamartoma excision?
So this is very rare. In my area, it's very rare. We just did 2 endoscopic cases. So
Okay,
nowadays there seems to be MR-guided thermotherapy. I think they use it for hypothalamic glioma most frequently. I would use it still if I have a case like this one, where I have a small hamartoma, which is purely intraventricular. Then I think it's a good indication. But as I said, we got only 2 referrals for patients with a hypothalamic hamartoma so far, so I cannot give you a large series. But I know from our colleagues in Germany that they prefer this MRI-guided thermotherapy, where they think it's quite useful to shrink this hamartoma or deconnect it. So I can give you not much more information. When I would see such a case, what we had, and it's easy to deconnect it with a ventricular scope, I would do that, because it's a very good result. And what's interesting, it's not only the improvement of the seizures, but the rage attacks, which was really a problem for the mother, completely disappeared.
Nadeem Akhtar, you want to ask your question?
Hello.
And Nadeem, you
Thank
have
you
to
very
speak
much.
loudly, please. Yeah, thank you.
Thank you very much, Henry. It was a very nice presentation, and we really enjoyed it. Just want to know how often you have to coagulate the bleeding. How much time you need a coagulating mechanical instruments to stop the bleeding? Normally, do you think that drainage can stop the bleeding?
Well, it's very variable. It depends what kind of vessel it is. If you have an artery, I think it will not stop easily. So I always try to coagulate it. I think that is, you cannot irrigate.
If it's minor bleed, if it's minor bleeds from the adjacent areas of the membrane, then
yeah, for example, if you have,
flushing.
if you have a small bleeding from the margin, for example, of an ETV, then of course you just irrigate, and sometimes it takes only 1-2 minutes and stops. Sometimes we place a balloon again in this area and we inflate the balloon and leave it for 2 minutes. And also this might solve the problem of bleeding. So it's very variable. It's very difficult to say. We had tumors, hemorrhagic tumors, and it never stops. So we have to switch over to microsurgery because there was so much bleeding. So it's very variable.
Okay, we're going to have 3 quick questions, and then we'll wrap this up. Adnan Khalik, Mash Shindra, and Sergey, and Agung Budi. These are the 4 question participants. So once we finish those, we can then wrap up.
Adnan, go on. You're switched on.
Hello, Assalamu alaikum, sir.
Understand.
Sir, kindly tell me, normally, routine we do lumbar puncture after just after ETV. So, do you recommend, and what is your experience regarding this this modality, having lumbar puncture after ETV? Thank you, sir.
No, we don't do that if the patient is doing well and we have no subgallia accumulation. So we don't close the borehole with something rigid, so we can see if there's increased pressure, the CSF comes out of the borehole and is bulging the gallia. And in this case, we do a lumbar puncture. But if the patient is doing fine, and we have like this case, what I showed you in tactile glioma, we would never make a lumbar puncture to increase the flow. I think it's not necessary.
Okay, well then Mashindra, I believe that's the name. I just came on. Next participant.
Hello.
Yes, Mashindra, please introduce yourself. Yeah.
I'm Dr. Machindra from India. And I want to ask, is there any size criteria for intraventricular tumors for deciding the approach, whether to choose endoscopy or microneurosurgery, like pineal cyst or colloid cyst, for example?
Yes, of course. Of course, we have to look at each patient individually. For example, if I have very small ventricles, very tiny ventricles, I always do a transcallosal microsurgical approach to remove an intraventricular tumor. If I have a colloid cyst and I see the content is probably very firm, it's a black signal and T2 weighted images, and I see the foramen of Monro is very narrow, then of course I do in microsurgical resection. So it's very variable. Always, you should not always do an endoscopic approach only because it's an intraventricular lesion. It depends from the size. It depends from the vasculature. Sometimes if I don't know exactly what to do, then I start with my endoscope, and if I see it's not working well, I remove the endoscope and I introduce a translucent endoscopic a translucent tube. This is from VCOR. This side tube is his name, and you can go in. If you follow just the track of the endoscope, then you are within the ventricle, and then you can use microsurgical instruments and can remove the tumor better. So we had some tumors which bled a lot after endoscopic resection, and then I switched to microsurgery.
Okay. Next question is from Sergey, please. So there'll be Sergey, Agung Budi, and Barbara as the last question, and then we wrap up. Sergey?
Sergey, please.
It's Barbara.
It's
Hi.
Barbara. Okay, Barbara, hi.
Hi, I am from Italy. Can you hear me?
Sure.
Yes.
Okay.
Yes.
Okay. I have not so much experience in ATV, but I performed one with endoscope for hydrocephalus with pinal cyst, and I am not able to perform a biopsy of the lesion, but the cyst disappear when disappear the hydrocephalus. What do you think about that?
That is a miracle.
No.
Well done, Henry.
So we had one patient with the pineal system. We made a follow-up, and he also came with a spontaneous rupture of his cyst. That can happen. We had it all seen in a Radke's cleft cyst, and we always saw it in a colloid cyst, but it's very rare. But usually, if I have a hydrocephalus because of pineal cyst, we always attack the cyst and would not do an ETV. And in most of the cases, we make a supratentorial, infratentorial supracerebellar approach to have a gross total resection. We have some patients with hydrocephalus. They said, no, I don't want to have the surgery. I want to just have an endoscopic fenestration. And we did a fenestration. But with the endoscopic fenestration, there's a higher risk that you get a recurrence, because we had 2 patients, they came back because this perforation, what you do with an endoscope, was closed after some years. But why is
Thank you very much, Henry.
I think we move on. We give time to.
With 207 participants on board, I think we could end up till tomorrow. You've got such a brilliant lecture, Henry. So I think if you can just put any final comments and we stop at the end of those final comments, that'd be very kind. Thank you.
Yeah. The comments are very simple. If somebody is interested in more details about the surgical technique, there is from Karl Stotz available a book. You can download it on the website, and there are all techniques described for fenestration, for colloid cyst removals, to how to make the resections of the arachnoid cyst. And we do also courses in Greifswald. We intended to do in August 26 to 28 a course, but I don't know whether this has happened. Moody, do you do your African meeting? It is at the same time?
No, we've had to reschedule that. A fresh date will be circulated once we decide.
Yeah, I also am down to do it. And then finally, I want to remind you on the meeting in India, the interim meetings of the IFNEF, and I would cordially invite everybody of you to come there. We are still not sure whether it will take place or not, but so far we look forward to it. Thank you for the attention.
Thank you very much, Henry. It's been brilliant. Thank you. Thank you very much. Salman, over to you.
You are the moderator, so you can take it away with Ramesh.
Ramesh, are you all set to go?
Yeah.
We're looking forward to your talk. Great.
Oh, thank you.
Ramesh is a dear friend, and he's actually a neurosurgeon and working in Charing Cross. Has been doing a lot of great endoscopy work, and we all vouch to that. It's, some amazing cases he's shown to us. So here you go, Ramesh. Show us your case.
Thanks, Salman. I can see Moody and Henry, and also I just saw Professor Khalid Mahmood, who I met in Karachi when I visited you. So I want to say good day to all of you. I don't know which time zone we are all in, and this is the best way to teach. And I appreciate and congratulate Salman for taking this initiative. And I think we're going to work like this for some more time. I'm going to start sharing screen from now on. Essentially, it's not about endoscopy today. I'm just going to show a couple of cases which I thought was interesting. Right. So, okay, you can see my slide.
Yes, go on.
Okay. So I will pause in between and then let somebody to ask them comment or questions. And in fact, I can ask them questions as well. And whoever wants to answer can raise their hands or let Salman or Moody know, so we can go. So first one, these two cases I'm talking about, they are management dilemmas. They're not particularly diagnostic dilemmas, but management dilemmas. And these are very difficult often. And there are many compounding and factors adding to the complexity of these conditions. The first one was a 30-year-old female. She was 12 weeks pregnant, her first pregnancy, and adding on to that sort of problem is that she's also a lawyer and also a medical legal defense lawyer. And then on a Saturday, about 2 years ago, she bent forward on a Saturday and felt sudden back pain and cramping pain right leg. Seen by the GP. You know, as you know, sometimes you can get sciatica during pregnancy and can get worse. So asked to manage it conservatively with some painkillers. But next day morning, the pain worsened and also started noticed some numbness around her genital area and some altered sensation in her legs as well. And it worsened by the afternoon and started having bladder problems, started having incomplete bladder emptying and a loss of sensation as well. Seen by the GP again, sent to the local general hospital and then transferred to my hospital. So admitted under one of our spinal neurosurgeons. Went on to have further investigations, and essentially her clinical examination revealed that she's got bilateral weakness, but mostly on the right side, especially the distal extremities, her ankle flexion and dorsiflexion and the externalus long were fairly reduced, and it had some reduced sensation, especially from the sacral dermatome, this S1 and S2 to S4 on the right side. And she did have some reduced anal tone and incomplete bladder emptying, and she was catheterized. So this is how her old picture. She's a young female, first pregnancy, 12 weeks pregnant, and high functioning individual. And as you know, the first investigation will be an MRI scan. Is that projecting well for you all? You can see the whole MRI here, mostly up to the upper thoracic and lower thoracic. And in the lower thoracic area, around T12, you can see within the cord, you see a lesion with signal changes within the spinal cord, mostly indicating edema and possibly a hemorrhage. And also, if you look carefully, you can see an increased vascularity around the cord as well. So you can see that, I think this notification is coming in my, so this is, you able to see the MRI scan, the lumbar sagittal MRI, and you can see at the lower end of the spinal cord where the conus is, you see hypointense area in T2 and some increased signals suggestive of increased vascularity. And on the axial section, you can see that swollen up spinal cord near the conus region and also the vasculature around it with a possible hematoma in the spinal cord. Essentially, she has a possible vascular lesion of the spinal cord. So this is where we have to decide. She is someone who has progressed in terms of her neurological function and deteriorated. And she has a vascular lesion. And the next investigation ideally would be, it will be a spinal angiogram. So the question is, what are you going to do? You're going to do a spinal angiogram on somebody who's in her first trimester of pregnancy, and you do that if you do want to treat her. And what is the risk of doing something? Either is it endovascular or is it open surgical procedure? What is the risk of it? This is all consideration. And if someone wants to answer what they would do next, whether they would want to wait and then manage this conservatively, or whether you would go ahead with further invasive investigations. Anyone wants to answer something, then feel to ask, or I'm very keen to hear any of you want to say
Henry,
something.
what would you do?
Salman, yeah.
Let's get Henry to tell us what he would have done.
So at first, I would try to improve the MR imaging. When I would do an MR angiography and more precise sequences, and if it becomes better clear what it could be, then it would be fine. If not, she is progressive in her neurological dysfunction. If she would be stable, you could also wait. But if she is progressing, so we have to do something. And then we have to discuss with her. She is in which months of pregnancy? First weeks?
12 weeks. 12.
12 weeks.
Yeah.
Yeah, I would discuss with her the best imaging quality would be in DSA in this case.
Yeah.
And whether she is accepting it. Is she thinking about abortion or not? This always, she has to decide it. One option is, of course, we do not make an MR imaging. We look at MR and have a clue what it might be. Is it an AVM? Is it a carcinoma, or is it a fistula? And we just make a surgery. It could also be an option.
I agree. Yeah, totally agree. This is where you need to have a thorough discussion about all the possibilities and the risks and benefits of each approach to the patient. The MR, we've had a fine cut MR and all these sophisticated techniques to look at this lesion. It seems like more like a vascular lesion, possibly an AVM, and it didn't look like a vascular tumor or a cavernoma. And she was very keen to continue with the pregnancy, but as well as to have further investigations. So then we went on to have the next investigation, which is the spinal angiogram. You can see that this is a left T10 injection, which very well demonstrates the artery of Adamkiewicz. And the classical appearance of the Adamkiewicz artery is that it goes up and then makes a hairpin loop downwards, and this is contributing to the anterior spinal artery supply. As you know, the artery of Adamkiewicz is one important artery in terms of the spinal cord blood supply. And this is one message I wanted to impart with this case, where to know about the artery of Adamkiewicz and the possibility of a spinal vascular lesion. Here, in the angiogram, you can see at the lower end, at the T12, there is a blush coming up. And I'll show you some more pictures so you get better understanding of it. So you can see the artery of Adamkiewicz is quite prominent because of the vascularity here. You can see at least two feeders with the venous varix possibly. And at the lower end, possibly communicating with one of the posterior spinal artery, which then goes back up because of the pressure. And I wasn't sure whether there is actually feeder from the posterior aspect of the spinal cord as well. This is in the anterior part of the spinal cord. This is an AVM by the angiographic appearance. And this is coming from the artery of Adamkiewicz. So just to show you the bony anatomy around that region, that's the catheter tip injecting the intercostal artery there, and T10 goes up, coming all the way up here. And you can see some pretty medullary venous congestion here. That's the lateral view. The arteriovenous malformation is here. And you can see also here from the anterior aspect, it comes, one of the feeders comes around and lighting up that AVM.
Could you put a pointer there, Ramesh?
Yeah, are you not seeing my cursor, or you're not?
You can see your cursor, yeah.
Moody, are you not seeing the cursor?
Oh, I'm seeing the cursor on this side. Yeah. Okay. No, I was looking at the lateral one.
That is the bony anatomy. That's the T12. It's just behind the T2 vertebral body, totally intramedullary, totally within the spinal canal. This is the appearance. So essentially, arteriovenous malformation of the spinal cord, they are not common in your practice. We do a lot of AV fistulas of the spinal cord, but these are not that common. So this is one thing. This is an unusual and rare lesion, surgery or any sort of management is often difficult, and especially adding on to the factors like she being 12 weeks pregnant with partial weakness makes the management more difficult. So this is what I wondered about, whether she's got another supply from the posture aspect as well. If you are thinking about any sort of treatment, you need to know which all feeders are coming into it. And this is the same as you decide about an intervention for a cortical AVM. And if it is a surgical intervention you're planning, the success of the surgery depends on you learning the angio architecture very thoroughly, looking at every feeder, each one, and you've got to be very precise. And it's got to be more precise for a spinal AVM specifically. This is not a lesion where the interventionist would want to go in such a long distance away and try to embolize it, given that it is the artery which can lead to major neurological deficit. Now, this is an artery which has a lot of importance, especially in thoracic surgery, as you know, and they have to clamp the aorta for aortic aneurysm repair. If they don't look at the artery of Adamkiewicz, it can lead to possible anterior spinal artery syndrome, possible paraplegia, and urinary and bowel issues. So this is very an important artery. So, and just to demonstrate, you know, spinal cord is supplied at various segments by various radicular medullary arteries, often by the intercostal arteries. But artery of Adamkiewicz usually around from T8 to
just one moment, Ramesh. There's a participant who says he cannot hear you. I suspect that the problem is local to him, because I had the same problem. I switched off and re-entered the link, and the sound quality improved immediately. So the problem may be with that individual's system rather than
local intervention as well.
Yeah. So I would suggest switch off and switch on again.
All right. Okay. So let me know if any other things we need to sort out. So this artery of Adamkiewicz is the artery that comes from the intercostal artery, and it forms two branches. One is an anterior branch, the other branch goes posteriorly, and it divides into a ventral and a posterior dorsal branch. And the ventral branch comes and joins the anterior spinal artery, which is a single artery. And then it's got an ascending branch, which you see on the angiogram. There's an ascending branch and a descending branch. I'll show this a bit further. And then it supplies the spinal cord around it. And in a cross section like this, you can see how it is like. You can see this is a typical appearance. You should be able to identify this artery on a spinal angiogram. Described by Albert Wojtek Adamkiewicz, is a Polish pathologist. And it's mostly on the left side, and 70% of population is on the left side, and often can come from T8 to T11, but the origin can be high or low. And at the end of the spinal cord, around the upper part, it can form an anastomotic circle with the posterior arteries, and then also contribute to the back of the posterior circulation. I'll show you some. This is an excellent specimen prepared by my very good friend Professor Victor Hugo he injected the artery of Adamkiewicz. You can see.
One moment, Ramesh. Rashid wants to make a point. Rashid, go ahead. Rashid, as your mic unmuted, you want to ask a question?
No, okay, proceed, please.
So essentially, so this is the anatomical specimen where you can see the cord icon at the lower part, and the hole is joining the anterior spinal artery and supplies the lower part of it mostly. And he's also very kindly provided injection of the artery of Aaron cleavage. This is the corticuna and the spinal cord in the middle. So that is the radical artery is pushing the dye inside, and then it goes up, and you can see it goes into the ascending branch, and then that hairpin loop, through the hairpin loop, it goes down to supply the lower part of it. It's a brilliant demonstration of the blood circulation of that region. So this is one thing about this artery and the relevance to this particular case. So my next question will be, how do you manage it? The interventionist would not want to touch this. And would you operate or would you leave it? That is my next question. I'm going to pause here, and Salman, if you want anyone to comment, please do go.
Okay, can we raise hands? Anybody wants to answer this? What would you do with this particular malformation?
Yeah, but whether you would want to, she wanted to keep her pregnancy. She didn't want to abort. And then you have an option to leave it, but also you have an option to treat it surgically. And mind you, the spinal cord AVMs are not very common, and it's a very high risk operation as well. Yeah, so
Dr. Waqas, go ahead. Dr. Waqas.
Yeah, he's on.
Waqas, you can start if you want to say something. Okay, he doesn't, so it's okay. So at the moment we have a comment from Ibrahim saying that is this an AVM and not a fistula? Is it clear? Is there a nidus?
It's very clear from the angiogram. It's an AVM of the spinal cord. Possibly there are different classification of it. This I would consider is on the pile surface with the clot underneath it, and it's on the cornus region.
And someone raised the query about radiation. Of course, they mentioned gamma knife, but obviously can't be given gamma knife in the spine. But is there a role for other form of radiation?
Yes. So I mean, it's a good question. If she wasn't pregnant, even if when there is an option to give stereotactic radiosurgery for such lesions, and one of the machines used for is mostly cyber knife, because it can use it in the lower part. As you know, with the AVMs, there is always a lag in terms of the response. The concern in this case is that she's pregnant, and her risk of, she has blood already, so there is a risk that she could bleed again. And if she wants, sorry, Henry, is it something?
No, I agree. I think
if she wants
surgery, you need surgery for her.
Yeah, so if she wants to keep her pregnancy, and with the advancement of pregnancy, it's very likely that her gravid uterus is going to cause more venous pressure, and she's going to bleed later on, and then can have a disastrous outcome from that. So we decided to go ahead with an operation in this case.
Waqas, you want to mention something?
Waqas Mehdi? Okay, I don't see him here anymore.
And
okay, Sorry, okay. we carry on, because then we have an MCQs to solve as well after this.
Okay, so so this is the exposure. A couple of things about the exposure. I would rather slightly go for a slightly wider exposure in these cases, because you want to, just like the cerebral AVM, you want to have a full exposure of all the feeders and the rest of the anatomy. And in fact, because this is a ventral AVM, you want to go very laterally as well, especially in thoracic spinal cord. This part of the spinal cord is slightly more mobile. In a thoracic spinal cord, you may want to go up to the pedicle and a very lateral approach. And my assistant is holding the cut dentate ligament to mobilize the spinal cord. This is a very useful way to do it. And this is where you can hold the spinal cord. There's no other place where you can hold the spinal cord at all. And that ligament is cut. And this raphe, it goes along the side of the spinal cord all the way down, which is a very useful structure to hold on to when you want to turn the spinal cord to visualize it. In fact, especially in thoracic area, if you really want to see the front, you may want to sacrifice on some of the rootlets as well, just to have a clear idea. Here I can just visualizing the feeder, can see that the main feeder is here, it's coming from the front, which tells me that it is coming from the angiospinal artery. And I'm not sure about any posterior supply. I cannot see unless I separate it and try to exhibit a bit more. I won't be able to see the supply from the back. So I would now try to get some more idea by injecting the fluorescein, which lights up. And you can see it's very bright, and the feeder is coming from below, which means the anterior part of it. And so here you can see it is lighting up. That is 2 feeders here, and there's slightly more.
What are you injecting, Ramesh? Is it ICG?
Yeah, so it is the indocyanine green, which I normally use for vascular lesions of the brain, and also for spinal area dural fistulas is very useful. And a few things about the use of this dye, because you can also see which one fills up first. That gives you an indication which is an arterial structure and which is a venous structure. And also it also gives you an idea about the completeness of resection later on as well, which I'll demonstrate. In the lower part, you could see another feeder, which I'm not sure whether it's going into the AVM. This is where you have to be really precise. In a cortical AVM, sometimes you take slightly a slightly less relaxed approach, a less cautious approach when you want to take some feeders. Here, you just cannot take any other feeder which is not going into the AVM, because the consequence could be quite bad. So it's going to go for the actual AVM. So once you identify the feeder, the manipulation is extremely delicate. You don't want to move any of these spinal cord structures. So my assistant is holding that raphe, which is along the side, which is where the dental ligaments get attached. You cannot really hold on to anything else. So here I will cauterize the feeder first, and then gently mobilize it. And just the rest of the surgery is fairly similar to an AVM surgery, but here you have to make sure that you're not dissecting into the brain. And Spetzer has described such AVMs like a pile surgery, where you just go on the surface of it, just excise the superficial part of it without going intramedullary, which is, I think it's a good technique. But here, medial to that, I know there is a cavity because she had blood, and possibly I was hoping that by removing it, the blood would come out. I'm just going to speed up here. So this is just cauterized it, and then I will just go around it right at the edge of that AVM. So once the dissection is proceeded, I am removing all the just the AVM. And
Agung Budi, you want to ask a question? Agung Budi.
Just go ahead. Just go ahead.
Okay, then lower your hand, please.
Yeah, so this is the last bit of that AVM coming out. You can see the rest of the spinal cord is intact. She's got some deficit already, and she's got deficit related to it, but you don't want to aggravate that deficit by any other manipulation of the spinal cord. So that is that part of the. So once you divide carefully, the AVM is excised, and the next step is to investigate the rest of the AVM. Because you can see there is a structure here, which I wasn't sure there's any remnant AVM or it's just a clot. So that it needs to be inspected very thoroughly. I found that it is all organized clot, and the question is whether to try and remove it. And it seems to be fairly firm. So I decided to leave it at that time. And because it wasn't coming out, and trying to remove it would have caused more neural damage. And I'll go for another injection to see that AVM is gone. I can still see some blush here. You can see that that's part of the supply, possibly coming from behind those nerve roots. And I suspect that is another feeder coming from the back. Here, this is a perimedullary venous congestion, and what I will do with this remnant is to coagulate without trying to excise it. It is somewhat similar to the pile resection advocated by Professor Spetzler. Here I will take each of these and I'll cut the feeder off and then coagulate that tortuous part of the AVM. So,
you're doing this under monitoring, right?
Yeah, so these patients are all monitored, and during the procedure there was no change in her evoked potential, and that part of the vascular I wasn't sure that is connected, so I left it because it was not really feeding onto the AVM. So I'm just going to, this is the immediate post-op MRI to make sure that there is no hemorrhage. And also with the several AVMs, you would want to keep the blood pressure a bit low, unlike you do for aneurysm surgery, for the risk of rebleed. Here also, you have to have some compromise because you don't want the blood pressure to go down too low, considering the spinal cord perfusion. Immediate post-op, she didn't have any further worsening of weakness in the recovery room, but then she did have further weakness in the next few days. But I wasn't really concerned about that worsening because that is not unusual to have some weakness after such an operation. But because she didn't have an immediate deficit, then subsequently she improved and then was discharged to rehab. She did have catheter and was on follow-up under the urologist. I saw her, I didn't see her, my spinal colleague saw her. She was walking with crutches, didn't have any catheter, bladder sensation was still impaired. When she was reviewed at 6, and normally for AVM, you should do an immediate post-operative angiogram. She was pregnant, so we didn't want to add another dose of radiation to her. So we decided that we'll do it later on. So she then had her delivery and had a normal baby. And then when she was seen in 6 months, she was walking better. She did have some improvement of her right leg power, especially the distal part, and the normal left leg was completely normal. Her bladder was better. Then I phoned her about 2 days ago, that is 29th, and she said she's doing much better. She doesn't need any more walking aid indoors. And the bladder is incontinent, but they're still keeping her under urology. They think that she may have some hypertonia of the bladder, but she's not on any catheter. So that is overall is a really good outcome as far as I'm concerned. And then she did have an angiogram a year later, which is fairly recently. So this you can see that injection around the T10, the same artery coming down up to T12, and the AVM is completely gone. So overall, this is a high-risk lesion in a very complicated setting in somebody who is high-functioning with 12-week pregnant and a medical legal lawyer. So overall, this suit I would consider as a successful operation, but it's not the case always. Sometimes you can have management dilemmas and surgery can be quite difficult. And also it depends on what kind of area you're dealing with. Any other?
Ramesh, I think it's a wonderful case. I'm sure everybody learned a lot from it. I'm sorry, we're just running short of time. So what we will do is we will go on to the multiple choice questions so that all the participants can solve it. I think the way you dealt with it and the way you, even during the surgery, how you manage it, I know majority of the people would have probably left it at that once you had taken the second feeder. So that was really, really good, very impressive. So these are, Okay, so these are, go on, let's come down to question 1. And I would ask Moody to take away these questions.
Yeah, okay, so as far as the questions are concerned, people are going to obviously tick their answers. Is there someone who's collating the results, or what's going on?
This is automatic. 123 people have already done this, so we are just going through it, and we can see the results underneath. So we'll just go through the questions now.
All right. So in endoscopic third ventriculostomy, the procedure should be aborted if which of the following structures cannot be visualized? And how does the responses go? Do people have
We will see the responses below. So we'll just go through the questions. Just go through the questions, and then we can.
Yeah.
Okay, go on to the next one. So obviously, the first one, I'm sure Henry can do this one. Or Henry, is it difficult for you?
Too difficult.
Okay, so second question.
Which is considered to be a contraindication? I think people are responding at the same time. Is that the plan, or are we going to?
The majority have done it, but people who haven't done it can do it now because it keeps changing as we go down. Yeah. Go on. No, sorry. Go on to question number 2. Yes, Moody.
Yeah. Which of the following is considered to be a contraindication to ETV?
Now that's interesting.
To determine whether the left or right lateral ventricle has been exposed, which simple rule can be used? Go ahead.
Okay, number 4.
The frontal horn of the lateral ventricle is posterior, anterior to the thalamus, medial to septum pellucidum, lateral. Is everybody able to see those questions? Because if they are, then I don't need to read them, surely.
Okay, so we can go below. Imad, can you take us below? Go.
But there were 4 questions.
Oh, we missed a question. No, we did all 4. Go on.
Yeah.
So go down. Okay, first question. Endoscopic third ventriculostomy. Procedure should be aborted. So once you see, if you can't see basilar artery and mammillary bodies. Okay. So some of the people still got it wrong. It must be Henry there.
Yes, I had this follow-up.
Okay, second question.
All right. Which of the following is considered to be a contraindication? The majority answered split ventricles.
So Henry, what would you say?
This is very difficult because
it is.
All 4 are considered by some people to be a good indication for ETV. In my opinion, in communicating hydrocephalus is not working well. So for me, it is communicating hydrocephalus.
It's actually, yeah, C is the right answer. Rest of them, yes, you can manage, but C, I think, may be an issue. Okay, let's go to third. Okay. Ramesh, you want to take this away, the third question?
What is the question? To determine left or right, exposed to which symbol rule can be used? Yeah, it might be the first one. Most of them got it right.
Yeah, okay. Then the fourth.
So the frontal horn of the lateral ventricle, posterior to thalamus, anterior to thalamus, and medial to septum pellucidum, and lateral to temporal horn. So everyone got it right, I think, is anterior to thalamus.
Okay, let's see what the presenter was like. So let's now be looking at Henry. Henry, it's excellent and good in majority of the cases, but 3 people felt that you're not up to the mark, or 3% felt you're not up to the mark, 4 people. 131 people responded of the 211 that signed up. And here we have majority again felt that your quality of content was excellent or good. And overall rate, let's go below. This is again same. You know,
There's a constant 3.8%. I'm just wondering whether they didn't understand what Henry was saying because of his.
It's me and my friends. I told them to do this. Okay.
Who didn't understand it.
And then, would you like to hear the same presenter again? And everybody except those 2, maybe 1 or 2 people who didn't want to hear you again, Henry. Okay. Did we do this for Ramesh as well?
Well, yes, sir. This is for presenter 2. Yeah, this is for presenter.
Yeah, presenter 2, Ramesh.
Salman, in my defense, I've got only half of this presentation. I could only do half of that.
So we double everything.
Yeah, I think this time Henry did a keiki.
He used all the time. Henry, you did the KK one?
What?
He's saying you did the KK. You know, KK Terrell. He uses all the time.
He wouldn't let go of the mic.
Okay, and then so presenters feedback, excellent, very good. And quality, very good. Excellent and good, excellent and good. And would we like to hear from him again? Yeah, there was Henry said
there you
no,
go. You're in
but
trouble,
everybody else
Ramesh.
said yes. 99.3% felt that we should hear you again. So it was excellent. I'm sorry that we couldn't finish it, but I'm sure we can do this, do it another day. Henry, your talk was brilliant. I'll ask Moody to say a few words and both of you to say a few words before we wrap up. Tomorrow's things with IFNE, WFNS endoscopy. We have Danny Prevedello talking about endoscopic anterior fossa meningiomas, and then Pepe talking about intraventricular tumor management. Then we have day after tomorrow, Greg Trost and Francisco Costa from Milan, and Greg Trost will be doing some cases along with him. And on Monday, we have, surprise, Danny Prevedello again, but he'll be talking about pituitary tumor surgery. And with him, Amjad Shad from Coventry will be joining him with a case or 2. So that's what we have. We have actually about 15 webinars prepared for next 3 weeks if this situation continues. But if it, if there is a change, then we'd let you know. If you have missed any of these presentations, all of these are available on a YouTube link through which we have recorded this. There were some questions asked by the YouTube link as well, but I'm sorry, I didn't look at that. So I apologize to those people who are seeing this on YouTube. And hopefully we should be able to look at your questions and answer. So here we go, Henry, Moody, and Ramesh, you can say a few words before we wrap up.
Everyone, I want to thank you for this initiative, Salman. Thanks for organizing this. I think it's very helpful. It's very interesting. Ramesh, your case is really amazing. And I think we should continue with the webinar. So we reach a lot of people, much more with our courses, hands-on.
I agree, Salman. This is fantastic you're doing. I mean, it's already 17 lectures so far. And even if this lockdown continues, even if it finishes, the outbreak finishes, you still have to continue it. It's such a, I think it allows everyone to participate by asking questions. I haven't seen this sort of response from the audience in a live meeting. So it is a great work.
Yeah, I would agree. I think, Salman, you've kind of set the benchmark, really. I think certainly from our residents' point of view and the world over, I think you're certainly leading by example, and the Pakistan Association needs to really be congratulated. They've done a wonderful job, and I agree with Ramesh that I think considering the success, and again, what Henry says, we're getting more responses and more participation on these than one would get on a meeting, really. So I would agree. I think even when the Corona stuff settles down, we should find a way of continuing with these. Absolutely brilliant. Well done.
Okay, thank you, everybody. It's a pleasure having you all, and hopefully we will have you again. Moody, you're due for a talk as well, so we'll keep you posted on that. Ramesh, you're going to finish your case, and I think you're giving a talk in about 10 days or so, as far as I can see. And Henry, obviously, we are going to continue with IFNE and WFNS endoscopy with these. So wonderful to have you again, guys, and we will see you again. But I still look forward to seeing you not virtually, but in person.
Yes.
Okay, take care, guys. Bye-bye.
You take care. All the best.
Bye-bye.